Bismillahirrahmanirrahim. Welcome to KFMRC's bi-weekly seminar. Today I'm going to present before you the topic Understanding Polycystic Ovarian Syndrome, Causes, Risk Factor and Treatment. Before this, I would like to introduce myself. My name is Ejaz Ahmad and I'm working in the Fundamental Applied Biology group with my group leader, Dr. Ahmad. We have worked on this paper and we have written a review, but still it is not published. We hope, inshallah, that it will be published soon. So now coming to the topic, Polycystic Ovarian Syndrome. What is Polycystic Ovarian Syndrome? In short, it is known as PCOS, and it is also known as Polycystic Ovarian Disease or Steen and Leventhal syndrome, because it was first discovered by Steen and Michael Leventhal in 1935. So Polycystic Ovarian Syndrome is a common, complex and heterogeneous endocrine disorder that is characterized by oligomenorrhea or amenorrhea, hyperandrogenism, and multiple small subcapsular cystic follicles in the ovary on ultrasonography. Some of the terms here I have highlighted, like common, complex, heterogeneous, and endocrine disorder. We will see why it is of importance. So we will see one by one the definition and I will explain it. It's common because it affects about 5 to 10% of women in reproductive age group. But this is just an average figure, because the incidence also depends upon many other factors like ethnicity, race. So in general, if you see worldwide, most of the papers report that it is 5 to 10% in the population. But as you will see in epidemiology later on, that it also depends upon the ethnicity of the population. The next is complex. It is a very complex disease because it has clinical implications, including it affects reproductive function, it affects metabolism, it affects the psychological features of an individual. So it is very complex and it is very difficult to diagnose sometimes, especially as I told that it was first reported by Steen and Leventhal in 1935, but actual reason for this and detailed research came only after 1980s, after the discovery of ultrasound, because as we will see in this that there are many features which overlap with different diseases and conditions. So it is very difficult to recognize. With just few symptoms, you cannot recognize that this is the disease we are addressing, that it is PCOS. No, it is very difficult sometimes. And it is heterogeneous. It shows different clinical features depending upon an individual. Some person may show some other symptom, others may show other symptoms, some may be even asymptomatic, but still they have some level of this disease. So we'll see how what is all about PCOS. And it is an endocrine disorder. As the name suggests, it is a polycystic ovarian disease. One might think that it is a disease of reproductive system. Yes, it manifests itself as a reproductive disease because it causes infertility. And we will see how it causes infertility later on. But the main reason is the endocrine disruption that is taking place in this condition. So it is primarily an endocrine disorder and it manifests itself as a reproductive disorder. It is one of the most common disease and this is the good news, that it is the most treatable form of infertility. Many types of infertility cannot be treated, or it is very difficult to treat. For example, there is a disease known as premature ovarian failure. If that is the disease, it is incurable. As far as we know, there is no cure which is known till date for that disease. It also causes infertility. So this type of disease, this PCOS can be cured, but if it is recognized early in the course of disease, and the patient often suffer too much before it is recognized, and sometimes it is misdiagnosed. This is also a big problem. So this is a graphic representation of normal ovary and a polycystic ovary. Just a brief, I will introduce you just now, then we will see in detail what happens. In normal ovary, there are primordial follicles which develop into primary follicles, and these primary follicles have FSH receptors on its surface, which binds with FSH, and then it causes secretion, it causes development of this primary follicle into secondary follicle, and then when the level of estrogen increases, and there is again release of LH from the pituitary, it causes the growth of this follicle, and finally ovulation takes place. But in polycystic ovary, what happens? The primary follicles develop, and after certain development, the process of maturation of follicle is stopped. So it changes into cystic appearance. It appears as cyst in the ovary, and finally it gives appearance of a cystic ovary. Yes? Yeah. No, they remain as such unless it is treated. I will show in the last how it is treated. It is important to remove this follicle. So you need to say they get accumulated, right? Yes, they get accumulated, and actually what happens, the cycle is very irregular in this case, as we will see now. This is a diagram of TS of ovary. Here you can see primordial follicle, and this primordial follicle is actually formed during embryonic stage in females, and it remains arrested in prophase 1 stage during embryogenesis. So a cohort of follicles are present already in mature female, and this primordial follicle develops into primary follicle. Primordial follicle is single layered cells, squamous epithelial cells, and in it is oocyte, and it develops into primary follicle. First of all, primordial follicle, the cells of primordial follicle is flattened, and then it changes its shape and becomes cuboidal, and it undergoes division and changes into primary follicle. So at a time, many primary follicles are formed, but when the follicle reaches 2 mm in diameter or more, a cohort of follicle is already there. So it changes into, some follicles changes into primary follicle, but from these primary follicles, only one become dominant. The other regresses. So the dominant follicle have more FSH receptors on its surface. So when the level of FSH comes down, they become irresponsive. Those which have less FSH, which are smaller in size. So naturally, what happens? Those follicles which are dominant, which are larger in size, which has attained the size of, in human female, it is about 10 mm in diameter. If it reaches 10 mm of diameter, it is known as dominant follicle. The other follicles regresses, and it undergoes atresia. Here is hemotoxin and eosin stained primary follicle, primordial follicle, and this is primary follicle. This is oocyte, and it has 2 layers of cells, theca externa and theca interna. Theca externa has FSH receptors on its surface. It binds with the FSH from the anterior pituitary. Anterior pituitary, there are cells known as gonadotropes, which secretes FSH. So it binds with the FSH, and then it continues its development. So the development progresses. It finally develops into secondary follicle, and then this is mature grafting follicle under influence of FSH, and then after that LH. It finally ruptures and the ovum is liberated. So this is the normal course of folliculogenesis in a normal ovary. But what happens in polycystic ovary? Before reaching this stage, the growth is stopped either in primary follicle stage or before its maturation into mature grafting follicle. And this is the menstrual cycle, 28-day cycle of female. Here you see that the maturation of follicle, how it proceeds. After about 14 days, there is rupture of follicle and there is ovulation. And likewise, here you can see the fluctuation in LH and FSH levels. This blue is luteinizing hormone, which is secreted from the anterior pituitary, gonadotropes. And just before ovulation, there is a surge, increase in the LH level, which causes ovulation. Plus, the estrogen, which is already being secreted by the follicle, growing follicle, helps in the development of endometrial thickening. But in polycystic ovary, the level of LH remains high throughout the cycle, and the level of FSH remains low. So due to low level of FSH, those primary follicles do not develop further, which requires FSH for their development. So what happens? They remains in their state, and finally they turn into cysts. This is the feedback system. You can see here, hypothalamus secreting GnRH, anterior pituitary secretes LH. In case of polycystic ovary, this LH is more from the beginning. And then the theca cell secretes androgen. And the androgen, normally it should convert into estrogens in the theca cells. But in this case, this pathway is somewhat affected. So what happens? There is more androgen. And androgen is the precursor of both estrogen and testosterone. So the cells do not respond to estrogen. There is no, the level of estrogen is low, very low, and the level of androgen is very high. So what happens? The androgen has its effect on the hair follicles and different systems of the body. So the female will experience the symptoms according to that. We'll see now. This is the appearance of polycystic ovary. This is 3D image. You can see these black spots. These are cysts present in the ovary. And upon ultrasound, this is normal ovary and this is polycystic ovary. See, this is only one mature follicle. You can see here, one mature follicle. Here you can see this is the outline of ovary. Multiple cysts. If the number of cysts is more than 9, or some papers report that if it is more than 12, then it is known as polycystic ovary. Sometimes there can be 2 follicles in normal ovary, 2 or 3, but only one becomes dominant and is released during ovulation.
But in the case of twins, it can be more than 1, 2.
Yes, it can be more than 1, but it is also possible that in case of twins, one ovum is coming from one ovary, the other from the other. This can also be the case. Now, this is again the image, polycystic ovary, and this is normal ovary. Here, one thing more I have added, that cystic ovary. One should understand the difference between polycystic ovary and cystic ovary because these are two different conditions, different diseases. Cystic ovary is actually when there's normal growth of follicle. Sometimes what happens that the follicle does not rupture and there's no ovulation. So what happens, there is still the ovum is trapped inside the graphene follicle and it accumulates fluid, causing it to swell many times. For example, if we see a normal follicle, maximum size of normal follicle through its diameter is 18 to 24 millimeter. But the arrested follicle in polycystic, it doesn't grow more than 9 millimeter. But in cystic ovary, it goes more than 50 millimeter in diameter. So it's quite huge. These are some of the physical symptoms. First is amenorrhea or oligomenorrhea, means absence of menses. Why it happens? Because of increasing level of androgen. Androgen has more or less effect like testosterone. So it affects since the secretion of estrogen is compromised, so it has amenorrhea is one of the effects. The other is growth of facial hairs and general growth of body hair like males. This is one of the effects of androgen. This condition is known as hirsutism, and it is quite common in women suffering from PCOS. The third is acne. It is again due to high level of DHEA, dehydroepiandrosterone, and other androgens. Receding hairline as in male pattern baldness. This is female, the head of a female, and this is a male head, showing the pattern of baldness. The hairline recedes from both the sides laterally. And in normal balding process in females, some females may have balding, but the balding is from throughout the head. There is thinning of hair from all over the head, and it is not like this. This is male pattern baldness. It is also known as androgenic alopecia, male pattern baldness. And obesity is one of the manifestations, you can say. It is caused by PCOS. Then acanthosis nigricans. It is blackening of skin due to deposition of melanin on skin, especially on folds, skin folds like on hand, armpits, neck. So this gives black and ugly appearance, and sometimes even face is affected. So you can easily recognize a person. But this acanthosis nigricans is not the characteristic feature of only PCOS. Many diseases like Cushing syndrome, a person suffering from adrenal diseases may also have this symptom. The other is skin tags. Skin tags is also very common, but in PCOS it is generally seen. It's more in PCOS. Now there are different criteria for diagnosis. As I said earlier, that it is a very complex disease, and it is very difficult initially, especially when there was no ultrasound. It was difficult to recognize the disease. So still there is no consensus on how do we recognize this condition, because it is a set of symptoms. There is hyperandrogenism, there is insulin resistance, diabetes, then there is anovulation, absence of or amenorrhea, absence of menses, or there is no maturation and ovulation of the ovum. So to summarize, this is just what most of the papers have written and what we think is the best criteria for diagnosis. There are three symptoms we have taken. Number one is oligomenorrhea or amenorrhea. This is shown here by red ring. The other is hyperandrogenism. This is shown by green ring. And the third is polycystic ovary. This is can be viewed on ultrasound. So this is blue ring. Now in all the cases you can see something written outside the outer layer side of the ring, and something is on the overlapping regions. So what we mean here is when more and more symptoms overlap, there is more chances that a person is having PCOS. So what we think is that there's diagnosis is done by exclusion principle. We exclude the diseases which are not present, and then what is remaining is the disease. For example, amenorrhea or oligomenorrhea is also caused by Graves' disease. It also occurs in perimenopause and Prader-Willi syndrome. It's a hereditary disease, Prader-Willi syndrome. So these are the causes of oligomenorrhea or amenorrhea. But one of the symptoms of PCOS is also amenorrhea. So we see other symptoms whether hyperandrogenism is present or not. If we take only hyperandrogenism, then hyperandrogenism is also caused by congenital adrenal hyperplasia and in acne or alopecia and idiopathic hirsutism. Idiopathic hirsutism has, one can say that there is no known reason why hirsutism is occurring in female. The female will show growth of mustache and beard, growth of body hair, and then there is alopecia, but it is unknown. So there are some chances still that hyperandrogenism is responsible for idiopathic hirsutism. Then adrenal tumor or Cushing disease also causes this hyperandrogenism. And Cushing disease is also one of the factors, symptoms found in oligomenorrhea. And the last is polycystic ovaries. But upon examination, it is seen that sometimes there is polycystic ovary, but no other symptoms are present. So that is also not considered as a case of PCOS. So when all the three symptoms are present, it is known as confirmed diagnosis of PCOS. But if some symptoms are overlapping, still a person cannot make cannot say that yes, for sure this is PCOS. This is according to the Rotterdam criteria. The Rotterdam criteria says that if any of the two symptoms are present, then it is PCOS. So these are the different criteria. In 1990, it was NIH criteria, National Institute for Health. It says only two criteria are required. So the prevalence rate is, of course, very small, 6% to 8%. In the beginning, I said that the prevalence is 5 to 10%. I said there are large discrepancy. Some population report some less than that or more than that. It shows a great disparity. The 2003 Rotterdam criteria says any two of the three, just what we discussed now. And in 2009, the Androgen Axis Society and PCOS Society, they both said that these two criteria are the hallmark. If these two are present, then it is PCOS. But there is no consensus on diagnostic criteria till date. These are laboratory testing to exclude other causes of hyperandrogenism and anovulation. As I said that what is applied is diagnosis of exclusion. So you exclude all other conditions in order to come to the conclusion that this woman is suffering from PCOS. For example, you have to evaluate for androgen secreting tumor, because when these tumors secrete large amount of androgen, all these symptoms will show up. And except polycystic ovaries, it will not show on ultrasound. but hyperandrogenism, insulin resistance, diabetes, amenorrhea, these symptoms are present there. So you have to remove this, exclude this androgen secreting tumor. Then late onset congenital adrenal hyperplasia, you have to exclude this. This is a congenital disease, and you have to remove, exclude Cushing syndrome and hyperprolactinemia. Hyperprolactinemia can also be caused by prolactinoma, which is a tumor, benign tumor of pituitary. It causes secretion of large amount of prolactin in blood, and this prolactin will not let the ovulation or maturation of follicles to take place. So this should also be investigated. And the last is thyroid function test, because thyroid also causes disruption. This is a new term, MyPCOS. It is for the assessment and management of PCOS. You take some criteria and assess on that basis the lifestyle and mode of living, and then different treatment involved. Like M stands for metabolic. You have to see the blood glucose level, check the level, whether that patient is suffering from glucose intolerance, insulin resistance, and diabetes or not. And like cycle control, to exclude other things. Then psychosocial, because partly due to increasing androgen hormone, there's some effect on the psychology of the person suffering, plus the physical feature. If a woman is showing features like male, it is she may be depressed, so it has its effect. So psychosocial, and of course cosmetic, and it affects ovulation and fertility, and it also causes sleep apnea. This is a new finding. It causes sleep apnea because of, maybe it has an independent role in sleep apnea, or maybe due to central obesity, which is found in this condition. Now, epidemiology. Most common endocrine abnormality in reproductive aged women. It's 18 to 45 years is taken into consideration because this is the reproductive age of women. Below this, it's adolescent years, and some of the symptoms can be confused with normal adolescent development, like irregular cycle. Irregular cycle is also seen in adolescence, so it might be confused. So later we'll see that what could not be developed now is accurate testing during adolescent years, how the disease progresses from adolescence to adult. On an average, about 5 to 10%, this is average, of women in this age group suffer from PCOS, and ethnicity is very important because there is great difference in the prevalence depending upon the population. For example, the most prevalent is, as is reported, is in Latino population, that is in Spanish population, and they have about 13% prevalence rate, which is quite too high. Then the Black Americans, on the other hand, have low 3.4%. So you can see the difference here. There is no finding on Arab population till date. We don't know how much prevalent it is in the Arab population. Yes, there is genetic basis, but we don't know of any particular gene taking part in all the process in the development. Yes. Yes. Yes, there is genetic basis also. Genetic plus it's also, you can see there are different races. There are different races also. No. Comparative? No, I don't know. Yes, yes. But it should be done ideally that they should compare the LH FSH levels of two different populations showing large differences. Yes, many, there are many. Even some of the papers, latest papers have discussed the role of environmental factor and the use of BPA, bisphenol. It is known as estrogen disruptor. So there are many factors. This is etiology. The exact etiology is not known. What is the exact mechanism? As is known in many diseases, many diseases we know the etiology, but here etiology is vague. It is unknown, largely unknown, and it is said that it is multifactorial. Not only a single factor is responsible, and there are different hypotheses given, but none of them have been proved to be correct till date. There is neuroendocrine derangement. As we see, there is some disruption in LH and FSH and oversecretion of androgens. And PCOS is characterized by inappropriate gonadotropin secretion, androgen excess, and often hyperinsulinemia, because excess androgen will make the cell irresponsive to insulin. So there is still glucose in the bloodstream. This causes increase in the glucose. The cells become glucose intolerant, and there is more secretion of insulin in order to enable the cells to move the glucose inside the cell. So this is insulin resistance, and this is pre-diabetic condition. It leads to diabetes.
This androgen is concerned with which glands?
Androgen is secreted by adrenal gland and also by you mean secretion or action?
I mean to say this androgen you have been mentioning all the time. This androgen has it been seen that is it from the adrenal, that is the sex steroids of the adrenal gland, they are involved, or other pituitary or the other?
No,
Yes.
it is also secreted from the ovary.
But that's what I'm asking.
Yes.
Is there any criteria or is there any difference which has been found that adrenal gland is involved or ovary or both?
Primarily it is ovary. Yes, primarily it is ovary. Even if adrenal gland is not involved directly, the ovarian steroidogenesis is involved in this process. So this is a summary of different theories. Some says that it is genetic predisposition and of ovarian androgen excess. This leads to polycystic ovary, and when more androgen, it will lead to more testosterone level in the blood, and it leads to insulin resistance, hyperinsulinemia, and diabetes. Some says that it's genetic influence, and the liver, which secretes SHBG, sex hormone binding globulin, the level is low, so there are more bioavailable androgens. So when there are more bioavailable androgens for the cells respond in that way, and this is one of the reasons for hirsutism. It is also thought that the main reason is maybe low level of SHBG, which can be genetic also. And the third is this one, that it is seen that if the small for gestational age is a factor, because those babies who are born with SGA, they had SGA, later in their life they develop polycystic ovary, and SGA is found mainly associated with IVF. If there is IVF, then it can be SGA, and due to more secretion of DHEA or treatment of patient with estrogens can also lead to polycystic ovary.
What is the difference of prevalence between like general population and type 1 diabetes?
What? Can you repeat?
What is the difference
Yes.
in the prevalence rate of polycystic ovarian syndrome in general population and type 1 diabetes?
in type 1 diabetes. It's actually type 2 diabetes mellitus. I don't know about type 1 if it is, I haven't seen any paper linking the prevalence with type 1 diabetes. Diabetes insipidus is type 1, right?
Because you're saying insulin resistance and
Type 1 is insulin dependent, type 2 is
Insulin resistance.
non-insulin dependent, NIDDM and IDDM.
So type 2 is mellitus.
Both are very
Both are mellitus. Okay. No, I haven't come across any paper, but it is known that it leads to diabetes. But we cannot say that if a person is diabetic, she will develop PCOS. No. Like in obesity. PCOS leads to obesity. But we cannot say that if you are obese, you will get PCOS. Is hereditary. There is strong genetic evidence and that genetic predisposition leads to PCOS, because when we see the patient, PCOS patient, about 35% of them have affected mother. So, and 40% of them have affected sister. So this shows that there is strong genetic predisposition in this PCOS. And diagnosis, how it is made? Yes. Yes. Yes, there are studies, but still, what we have seen is there's no particular gene which is earmarked as that this is responsible for PCOS. So it is multifactorial, even on genetic basis. Maybe there are many genes interplaying and their role with environmental factors, but still it is not, we cannot conclude anything on this. Diagnosis, first is physical examination. The patient is examined for features of hyperandrogenism like acne, hirsutism, deep voice, male pattern baldness. And one thing I would like to say is actually it is the estrogen hormone which keeps the, since androgen is the precursor of both estrogen and testosterone. So estrogen inhibits the action of testosterone, limit a small amount of testosterone if it is present in the female, or the action of androgen. So when there is no estrogen or the estrogen is quite low, so these androgens show up their symptoms, these symptoms. It is due to the excess androgen. Likewise, if a male is injected with female hormone, there's again changes which takes place by estrogen in female. Then chronic anovulation and increased BMI and waist hip ratio. Obesity is one of the things it should be investigated. And infertility, they are generally unable to conceive, but it doesn't mean that it causes permanent infertility. This is not the case. And there are chances that they can, but the chances are low. And pelvic examination can be, manual examination of pelvis can show, doctor can palpate to see the ovaries are swollen. But the confirmatory test can be done only through blood test and final ultrasound of the ovary. Upon ultrasound, it is seen that hyperechogenic enlarged central stroma, the ovarian volume is increased. And peripherally arranged microcysts, as we saw in the ultrasound, the cysts are arranged peripherally, and more than 10 immature follicles measuring more than 6 mm in arrested state. Laboratory test serum prolactin to rule out prolactinoma, because it also causes amenorrhea, and DHEA level should be examined. How much free DHEA and how much combined is present in the blood. Here you can see what I said. This is androgen, these are androgens, and it is aromatized to estrogens, and the other pathway is for the secretion of testosterone. So they are coming from the same precursor. This is an overview of PCOS manifestation: insulin resistance, hyperandrogenism, hormonal imbalance, metabolic syndrome, and psychological problems. This is pathophysiology of in comparison between the traditional and modern concept. It was traditionally believed that hyperandrogenism and anovulation caused by abnormalities in ovaries and adrenal. But now the genetics is explored, and the genetic basis, the scientists are trying to find out what is the genetic basis of this disease. It was thought that obesity is the cause. Earlier it was thought that obesity is the cause of PCOS, but this is not the cause. Rather, today it is insulin resistance is being researched upon. Then hypothalamo-pituitary area was more under consideration, and now hyperandrogenism is considered more. These are the possible health effects of PCOS. PCOS can lead to obesity, and obesity as per se do not always lead, but sometimes due to insulin resistance and hyperandrogenism, it can lead to PCOS.
What about PCOS leading to obesity? Is it always that?
No, it's not always. Just as I said that it's a heterogeneous disease, symptoms are different. You may also find lean women having PCOS. So this is not the case always. So adolescent obese women more likely to get PCOS. The chances are high, but not always. And PCOS leads to obesity, but obesity does not always lead to PCOS. Then it leads to, the obesity is also linked with CVD. And PCOS also is linked with CVD. Yes. No, actually, obesity is not only the characteristic feature. Yes. Maybe some genetic factor is responsible. Then insulin resistance, it leads to diabetes, and diabetes is linked with CVD, we all know. Then obesity and PCOS can lead to endometrial cancer. Endometrial cancer. Why? How it happens? Number one, that we saw in that figure where I showed the menstrual cycle. There is what happens here. It is unopposed androgens will cause thickening of endometrial lining, and this leads to endometrial hyperplasia. And this endometrial hyperplasia, if it is not treated, it will lead to endometrial cancer. So the chance of endometrial cancer in PCOS women is quite high, but it develops after the age of 40 or 45. It is not commonly seen in young women because it takes time. The treatment are symptoms and age are the main determining factors for the mode of treatment. If there is menstrual irregularity, then these are the lifestyle modification, oral contraceptive pills, insulin synthesizers like metformin, myoinositol, and earlier proglitazone was also used, but now it is no longer in use because it has a hepatotoxic effect. So it is no longer prescribed. And anti-androgens. Anti-androgens are also, they have also side effects. They are carcinogens. So it should be taken after considering all the other possible treatment.
But in case of metformin,
Yes.
metformin also has the hepatotoxic effect, especially in fatty liver disease. So if a person is obese already, female, then metformin, is it a drug of choice or first what it is?
No, it is not always prescribed. Metformin is not always prescribed. Rather, it is prescribed after taking all the different symptoms and conditions into consideration, plus the age of the woman. Because metformin is an insulin sensitizer. It increases the cell sensitivity to insulin, and so it helps in the uptake of glucose by the cell. And when this takes place, there is lowering of androgen. So when there is lowering of androgen, it promotes ovulation. So metformin is also it is used in this, but taking everything. Metformin also has one more side effect. It causes osteoporosis. So everything is considered before prescribing the medicine. So insulin sensitizer like metformin, it increases the cell's sensitivity to insulin. This causes this helps to overcome the insulin resistance and improve glucose utilization, and it also reduces the free serum and androgen levels in the blood. So there are less free androgens, and so the symptoms which are related to hyperandrogenism, it can be cured. And it also improves fertility rate, restores normal ovulation. This is the structure of metformin, and it acts by two pathways. First is by insulin. It affects the insulin binding with the cell, and other is it promotes gluconeogenesis in the ovarian cell. So it lowers the androgen secretion, and it also helps to convert androgen into estrogen. The other is inositol, and inositol is a carbohydrate, and it is found in natural products, natural food. And how it acts: the inositol binds with the receptor, forming inositol receptor substrate, which activates the phosphonatidyl 3 kinase, and which also activates GLUT4. This is insulin regulated glucose transporter, and this GLUT4 is translocated to the membrane, and it allows the glucose permeability in the membrane. This is how the inositol deficiency leads to. It causes decrease in the level of PI3 kinase, which affects the glucose intake and hyperglycemia, and finally hyperinsulinemia and PCOS occurs. If the PCOS is diagnosed in childbearing age and the main problem is infertility, then the main focus is on ovulation. When I'm discussing this, it means that other symptoms are not visible, or it is not of concern, like hirsutism is not present, or is not insignificant, is of significance. Then this clomid or clomiphene citrate is used. It improves the ovulation, and it prevents multiple pregnancy and abortion. The other treatment is surgical treatment. Here you can see this is ovary, and these are the cysts. Here it is very clear. So by laparoscopic drilling and diathermy, the cysts are neutralized. It is neutralized so that it no longer have its effect, and it is finally it is also suction out, and then the laser is used to seal the membrane of the ovary. So these are the treatments used. Still, there are knowledge gaps in the understanding of PCOS. As I said, there is absence of specific diagnostic criteria for identifying PCOS in early adulthood, because amenorrhea can be present in early adulthood. One or two symptoms doesn't mean we cannot draw a conclusion that the patient is suffering from PCOS. So there is no certain diagnostic criteria to determine when we can say that adolescent is suffering from PCOS. As far as hirsutism is concerned, there is no known what is the best medical therapy for hirsutism. Is it anti-androgens, or is it laser treatment of hair follicles? Because anti-androgens have its side effect. So laser treatment is considered, but it is not the root cure for this condition. And how long therapy should be continued? How best to evaluate hirsutism, because hirsutism can be idiopathic as well. Then we see if there is menstrual abnormality, it is unclear to what extent the severity of menstrual disturbance is associated with the severity of PCOS phenotype, and the progression of menstrual irregularity in PCOS are not well understood. It is not well defined. when can you say that this irregularity shows some of the signs of PCOS? It is not defined, so it is difficult. It is not known whether PCOS patients have a longer reproductive lifespan. How long do oligomenorrhea or amenorrhea women ovulate? How often? And about obesity, does PCOS predispose to obesity, and does obesity unmask latent PCOS? It's still not known. In conclusion, as these symptoms or this condition affects different age group differently, and there are different criteria to judge. In adolescents, we see that acne is common in both PCOS and non-PCOS group women. So normally an adolescent will develop acne. We cannot say that yes, if it is acne and oligomenorrhea or amenorrhea, it is PCOS. No. Hirsutism is in about 70% of PCOS patients. But here, one study is conducted in Saudi Arabia in Riyadh. I think it is in King Saud University. That shows that Saudi women have less hirsutism. The PCOS, Saudi women suffering from PCOS have less hirsutism. So this should be investigated more. And there seem to be ethnic predisposition to the progression of hirsutism. And of course, menstrual irregularity is there, is a common suffering. And in a study conducted in King Khalid University Hospital, Riyadh, 89% of patients suffering from PCOS had menstrual irregularity. It was reported by Al-Ruhaili. So this is the conclusion. Insulin resistance and diabetes. It is one of the common findings to have insulin resistance in PCOS patient. And there are different mechanisms by which this insulin resistance occur. And there is some degree of damage to pancreatic beta cells also. It was reported by Ahmad 1995 and Messer 2013. This is latest paper. If anyone of you is interested to know more, this is a paper published in 2014. PCOS update on diagnosis and treatment. It's one of very good paper. Tracy et al. These are the references I used. One or two references are from Saudi Arabia. Any question if you have?
What is the minimum average age for a female
To diagnose?
chances of
Are you asking about average age or when should it be diagnosed? Actually, actually what happens that many cases develop PCOS right after adolescent years. Many cases. So it is difficult to recognize whether it takes place, it starts during adolescence or after adolescence.
That's why I said average because population can consider 14 years, 16 years, 18 years after that.
Actually,
Report in the literature for this?
no, we haven't come across any report in the literature saying that average age is this or after attaining puberty, this is the age.
Mostly related to the process of population.
Yes.
That's why I can see that after this,
Yes, maybe. This is a very good question because it should be investigated. As many papers have reported that actually it starts right during the adolescent years.
very critical
Yes,
point to
yes, because maybe initially it is in latent stage. It is not. Maybe it is difficult to find out right after adolescent years that it is the patient is suffering from PCOS because it's not necessary that all the signs will come together.
yeah,
Maybe
asymptomatic also
yes.
symptomatic menstruation.
Yes, yes. So it's a very good question, and this point should be researched.
You found that it is genetic variation that it's two different
Yes,
cases of mothers and then.
yes,
So does that mean that some women have normal pregnancy first and then they develop?
yes. Of course.
So
Yes, of course. Yes, it happens that some women may pass after yani reproductive age 25, 30 years, then she might show up other symptoms like oligomenorrhea and yes, yes, this happens. Yes, initially they have normal pregnancy, and after a few years they develop PCOS. Yes, this is also reported, and uh, there is one more thing I forgot. I was trying to say, discuss on that issue. One more thing yes,
This was PCOS. It conceals. The baby born, has he or she any problems with the metabolic disorders? Is it good?
if the woman is having diabetes with PCOS, then she should be under observation throughout her pregnancy.
No, I mean baby.
The baby, yes, a baby might be LGA, large for gestational age, because this is a feature if a mother is having diabetes, because she's suffering from PCOS, right? The mother is suffering from PCOS, and the chances are that she is having diabetes also. So if she's diabetic with PCOS, then she might have the baby may be LGA. But as far as the child is concerned, I haven't come across any paper which shows that she has such defect or such a congenital problem. I don't know about this. Any more questions? There is one thing I wanted to discuss, but the role of leptin is very interesting. But since it's another site, so I dropped that. Leptin is very interesting. So anyone, if you want to continue, want to do some research, can do on leptin and also on ghrelin. Yes. Any more question? No. Thank you. Alhamdulillah.